Yeah, I'm going to talk primarily about the meta-analytic study that we did and some updated. I've been running analyses the last couple of days trying to update some of these analyses for this, and I can run more if the group needs them for their deliberations. A couple of background things. I heard some discussion of ADHD. I just got here this morning, so I missed yesterday's, but I want to just make a couple of general points about what ADHD is relevant to this. This is generally thought of as modeled primarily as a complex disease, meaning it's similar to things like cardiovascular disease and obesity, with the presumption that there's multiple genetic and environmental inputs, multi-causal, a lot of heterogeneity in the expression depending on context. It's a dimensional trait construct, kind of like hypertension, where we have a cut point that has tries to balance the right time to intervene. As we like to say about blood pressure, you know, God loves 139 almost as much as 140. And when it comes to ADHD, 5 symptoms almost as much as 6. And so there's a spectrum here. There is considerable evidence that it behaves like a trait in the population. A lot of this is genetic evidence showing that the genetic effects, whether they're molecular or quantitative, do not change as you go across the spectrum. But there are no genes we know from massive studies. There are tens of thousands of kids that there are no genes of major effect. There are hundreds or thousands of genes that play a role, much like the same for height and other quantitative traits in the population, height and IQ. Many, many genes are involved. And the model here for most psychiatric illness is that it's an accumulation of risk factors. I think about the model of asthma, where you know, to have an asthma attack because this went wrong and this went wrong and this went wrong, and now you have an asthma attack. And so you can start to remove those triggers and sort of reduce the risk. And similarly for ADHD, the more risk factors you add up in the context of genetic liability, the more likely to have clinical symptomatology. And this model seems to be supported by most of the data. It doesn't mean there may not be subgroups with actual neurological injury early in life, and we're very interested in that. But there's also this large trait effect. And just to add to the literature on the effects, we published a study a few years ago that the ADHD symptoms, as rated by teachers as a quantitative trait in the general population, are a very powerful predictor of academic outcomes, more so than other behavior problems or IQ. So very important in many ways to outcomes. Important to recognize the non-specificity here. Attention symptoms don't occur in a vacuum. They're overlapping heavily with other disorders in various ways over development. Part of why ADHD is so costly and so important is it's kind of a gateway to these other problems. It's the earliest of these conditions to develop, with the exception of autism. But it doubles and triples the risk of these other conditions, depression, addiction, and so on. So it's a very important kind of early marker, and its impact on overall mental and public health is therefore much larger than just from attention problems alone. You guys have already talked a lot, it sounds like yesterday, about mechanisms, but we presume that these multiple environmental inputs may have common pathways biologically that lead to this outcome, but this is largely to be determined. Just as a context, you may have heard this already, so I won't belabor it, but there's been a decades-long interest in the question of dietary inputs and ADHD behaviors, but the experimental literature around food diets only began in the 70s and 80s. The two basic designs that you've probably heard about are either to try to restrict the diet, taking out all the foods that have additives in them. If you do that, of course, you're restricting things besides food dyes too, because the dyes are generally not the only thing added to food with things in them. But it is a clinical intervention trial that allows you to see what would happen to a child if you do this and restrict ADHD symptoms. And the other is to do a challenge trial, like Dr. Stevenson talked about, to isolate causality. And we in our meta-analysis, we looked at both kinds of studies. I'm going to focus heavily on the experimental synthetic dye challenge studies, but I do have the data on the food restriction studies if you want to see them, but Dr. Stevenson did already point some of that out. A key question in this literature is the definition of ADHD. I just want to provide a little bit of reassurance here. The disorder itself has been redefined many times. When this literature started in the 70s, there was no ADHD definition as we think of it today. The disorder was well known in the literature, but its formal definition had not yet been developed. It happened in 1980 with DSM-3, with operational criteria. But the rating scales of the Conners rating scales are the main instrument used in most of these studies for hyperactive outcomes. And that instrument was first developed a little before the DSM came out and updated many, many times since then, but with a certain amount of continuity, particularly in the short form item list that is commonly used in these studies. So there is some relatableness to how ADHD or hyperactivity was operationalized in most of these early studies and today, even though there's many cultural and historical changes that we can talk about what the symptoms mean over time. I'm not going to, you all have already talked about the food dyes. These are the meta-analyses that have been done, and Dr. Stevenson mentioned these. The first one, Schaub and Trim, and I've put up here the number of studies they had and the effect sizes. You can see that these meta-analyses varied with effect sizes of 0.1 to 0.4. They varied in whether or not the effect size escaped 0 for the 95% confidence interval. They varied widely in what studies they included, how they selected their studies, how they conducted their analyses. Ours is the most recent meta-analysis, although it was done in 2012, and like I say, I've had a little bit of updates that I'll give you. I've shown here our reported findings for different kinds of outcomes, and I'm going to go through those in detail. This is just one of this is what Jim mentioned already. This is restricting to ADHD kids and using diet restriction, and you already saw these data showing that there is an effect on ADHD when you restrict food dyes from the diet. Here's the design for our study. We did an extensive literature search. Our paper describes all the different search terms we used. I'm very confident we found every study because I've looked at the reference list for every study on this that I could ever find, and I don't think there are any human studies that we weren't aware of at that time. There's been one subsequently to that, but I still don't know of any that we missed to consider. We looked in 2 groups of studies, those that did a diet restriction. We ended up with 6 usable double-blind random assigned crossover design studies there, and we found 25 that were food diet challenges of one kind or another. And our requirements are listed here. They were that it's a placebo-controlled double-blind study, either a crossover or a random assignment, and with children or adolescents. As it turned out, most of the participants were pre-adolescent children. And we had to be able to compute effect size. We were pretty good at that. We were able to get an effect size out of almost anything, but there were 1 or 2 where we couldn't get an effect size, including the aforementioned study Locke et al. That just came out in Hong Kong in 2013, which I'll come back to. This is a list of our studies. Too small to see, I apologize for that. I'm happy to show it to anyone afterwards. But it shows the studies plus the 2 at the bottom in red that I'm going to talk about in a minute. So I'm going to first go through the results that we presented in 2012 in our paper, and then I'll talk about some updated refinements of those analyses that I ran through this week just to give a little more focus for you. So this first slide, again, the screen is pretty small, but you do see here the top section is the parent results, the list of studies there. You can see that most of these studies had small n's, gigantic confidence intervals. Many of the confidence intervals touch 0. However, almost all the points are in the direction of food colors are harmful, and the consensus effect is quite robust in terms of its p-value and its confidence bar and its effect size around 0.2, a little less or more depending on what kind of stratifications and checks we do on the data, which I'll go through. The teacher data, the effect size is just a little bit smaller, and here the confidence interval just touches 0, so the p-value there is just a little bit above 0.05, but again, the general effect is pretty similar. And then very interestingly to us was that these tests of attention, there were a number of studies that used laboratory tests on food diet challenges ranging in time from a couple of hours to a few days, and then gave various kinds of tests of attention, paired associate learning tests, computerized performance tests that Dr. Stevenson mentioned, and others. And we went through a process of having 2 expert neuropsychologists evaluate these tests in terms of whether they were tests of attention or not, or whether tests of language or tests of memory or what they were testing, and get consensus categorization of the test's primary cognitive function. And so we limited here to the tests of attention. There were also tests of motor ability and other skills. And this result here, you can see the wide confidence interval, the small number of studies, but again, they're all in the same direction, essentially, and the effect is in the same neighborhood of size as for parents and teachers. So quite a bit of consistency across these measure sources. And for studies such as the Southampton study that averaged, we broke those apart. So we put here the Southampton parent data, teacher data, and test data separately. And we did that for other studies that were similar. So we were really interested in the extent to which the effect would show up across sources of information, because any one source of information can be criticized. You know, parents maybe somehow are not as blinded as the teachers are. The teachers don't see the kids in different settings the way parents do. The tests are objective, but they are not only correlated to a limited extent with real life behavior, et cetera. So each approach can have its criticism. So the degree to which there was similarity across these approaches was of interest to our interpretation. Now, I do have a slide that I can show during the Q&A, but we did look at whether the effects were limited to kids who were hyperactive or not hyperactive in selection, and also whether or not they were pre-selected to be diet responsive, and no difference in effect size. And in fact, for the parent data, the effect size is essentially identical in the studies that used general population, unselected kids, and those that selected their kids for hyperactivity, kind of confirming the idea that that this effect size doesn't vary across the range of hyperactive symptoms, although again, the data, the sample sizes are very small for that comparison, so it's somewhat provisional. And many of the studies that had, I'll just leave it at that. We'll come back to this if needed. This is just to isolate studies that looked at dyes only. As Dr. Stevenson mentioned, their study included preservatives, and there's several studies did do that because that was the original, one of the original theories from Feingold that was very influential, was that dyes, preservatives, and salicylates are the causal factor in foods, additives, and so many studies tried to look at those combinations. So studies looked at dyes only. You see the effects are very consistent across reporter sources. I don't have your confidence intervals here, and I left the standard errors off, but you can see from the p-values that get an idea of those ranges. But several studies in Europe included dyes that are not FDA approved. When they go to the FDA approved, the effect sizes were quite a bit smaller, but still in the ballpark between 0.1 and 0.2. You can see that we lose quite a few participants here. Notably, the attention tests all were studies of FDA-approved studies and dyes and effect held. I'm going to skip this. This is the data on the publication bias that we presented in our paper. I'm going to go through this in detail here and also show you results with some additional studies added from two sources. So we looked at there were two studies that we didn't include in our meta-analysis that one could argue we should have. One is a study from Carter et al. That we excluded because they had selected the kids to be diet responders already, but we've had others tell us that should have been included by our own exclusion criteria because other studies did have that feature as well. So I also ran the analysis with them included, which is the second set of results here. And then the third is I've written to Christine Locke. I cannot understand their paper in terms of what the data are very limited, so you can't tell what the effect size is in that paper. I've written to her to ask for the effect size data and have not heard back, so I can recheck this. So I assumed the effect was 0.0 for their effect size and recheck the results that way to give a worst case scenario there. Because they did indicate in their text that they didn't say that the food dyes made the behavior better. They indicate that it was just not as significant. So first of all, as we reported in 2012, the p-values there fairly robust. The effect size 0.18. We add this small additional study from Carter. We get an effect size of 0.2. If we then repeat our analysis of the highest quality studies, we did some quality assessments, the quality of the ADHD measure and the quality of the blinding. You see that the effect shrinks a little bit, but is still reliable. We looked at dyes only, the effect is a little bit bigger. And if the blind is validated, very few studies actually validate that the blinding worked, which is a big concern in this literature for the parent data, of course. It's one reason we like the attention tests, and I think the teacher data also deserve consideration despite the limitations. But here in this case, those 7 studies showed the same exact effect size, suggesting that the blinding is probably not a big issue in the other studies. When we add Locke, which is a fairly large study, 130 kids, assume the effect was 0.0, you can see that the overall effect size with both Locke and Carter actually doesn't change much. If we look at unrestricted, it's a general population study, so we can see that those that are not restricted to ADHD, we have 9 studies now, effect size drinks to about 0.15. So this shows you again that the effect is still there in general population studies overall, even with Locke being counted as a 0 effect. And not selected as diet responsive, same thing. FDA only still holds for the parent data as it did before. Or I should say holds a little better. Now, the issue here is the publication bias. And this is probably the biggest weakness in the literature for the parent data. And what you see here is that if we look at publication bias, the idea that small or null effect studies may not have been published, the file drawer effect, this is just a trim and fill. We've actually looked at publication bias in multiple ways, but the trim and fill is kind of an easy one to understand. It proposes an alternative p-value corrected for possible publication bias. And the number of studies imputed gives you a rough idea of the degree of bias. There's a number of other parameters the analysis gives you about the degree of bias. But what's important here to see is that the effect size shrinks a little bit into the 0.12 to 0.15 range, depending on which stratification we do in our initial report. And then you see is in the initial report, if we go to dyes only, that there's a suggestion of significant publication bias, and that effect shrinks down to about 0.08. However, adding just one study back in, the Carter study, that restores that effect size quite a bit. So there is still vulnerability here to just a single study variation here in that estimation of the dyes only. But if you look at all studies, I want to emphasize here this piece on the Carter one here, that effect size for all studies corrected is 0.12, whether or not you include Carter. And then when you put Locke in there, a big study, that reduces that effect down to 0.1. This is just the trim and fill plot to show you where the studies were that were imputed for those that are interested in that, and I can go back to that in detail during Q&A if you're interested in it, for the parent report. We did run some meta-regressions on the parent data, didn't see any associations, but just to give you a flavor of this, let me just show you a slide of this in a minute. Just to see, the meta-regressions really weren't very informative, and you can see why. There's a wide range of dosages and one outlier dosage there that carries any effects you'd observe. So we'll come back to that and if you want to, but we didn't see big dose or other kinds of effects in this literature based on just the distribution was so wide. The teacher data here, and the story here again on the publication bias reduces those effects, but otherwise the effect sizes are a little bit smaller here. But for colors only, they're identical, 0.22. We add this study in, we get a little bit of modification. Locke et al., if it was a 0 effect for teachers, would reduce the effect further. But as you can see, the effect is very sensitive to various stratifications of the data. If you would take out outliers, if you think about high quality, low quality studies, if you combine those things, the effect size moves around quite a bit. So there's a small number of studies The effect size estimates are somewhat vulnerable to one's stratification choice and study selection, which is part of why the meta-analyses range in their estimates, but the range nonetheless does run from about 0.1 up to about 0.2 or 0.3. This is just another look at the funnel plot for publication bias for teachers, and you can see the same problem there, that effect that's slightly non-zero, reliably non-zero there at about the 0.15 range. The confidence interval begins to touch zero when you take into account possible publication bias using this method. So come to the attention tests, which we think are very important for the reasons I mentioned. This is all the tests of attention here, unstratified, adding in the Carter paper. And you can see here again how small these studies are, with the exception of the McCann paper, which is fairly large. But you see the robust effect size there, 0.25. This is not subject to publication bias. There's no evidence of any publication bias here. The effect size stays the same if we omit Carter. It stays about the same if we omit any one study. You can see at the bottom line there, omitting any one study, again, a little hard to see, the effect size ranges from 0.19 to 0.30, and in all cases, the confidence interval does not touch zero. So the actual laboratory tests that are not vulnerable to rater bias, not very vulnerable, they're still somewhat vulnerable to culture effects, but not as much as raters are. A pretty robust effect that's not vulnerable to stratification of studies or to publication bias. And this is probably for us one of the most important observations that we had, that the ratings data move around a little bit depending on how you slice and dice the data, but the attention test data do not. This is just a regression on dose. There actually is a significant slope to this line, but you can see it's carried by one outlier. So it's really difficult to know if there's a dosage effect here in the attention test. So the conclusions I have are here, and I apologize for not making these animated, so you got to look at this busy small text slide, but I'll walk through them here. The conclusion that I've made from this to this point is that there's something there, but it's hard to tell what it is exactly. It doesn't seem to be restricted to hyperactive kids. The effect sizes are statistically small, but as Jim pointed out, and I'm sure you have statisticians in your group that can do these calculations, we've done them. They've been done for lead. They're pretty straightforward. If you convert this to the number who might be pushed into the disease spectrum over the line, just like if you factor in the effects on cardiovascular disease diagnosis, if you start adding risk factors to the population, the effects of this size are quite clinically important in the population level. And I think I would have brought you the numbers. I had thought Jim, in one of his earlier versions, had these numbers from the lead literature that Bruce Lampier's group did, but they converted these in and showed that for lead and IQ, the percentage of kids who would move into the designation of intellectually disabled with all the costs and interventions, or the reduction in kids classified as qualified for advanced learning and intellectually talented, would change by lots, big numbers of kids. And the same thing here with this effect size. If it is 0.2, that would change the percentage of kids pushed in and out of ADHD if this effect is to be believed. So the effect size, I think, is an important effect size from a public health point of view, even though it's not big enough to account for most cases of ADHD by itself, or to say that this is anywhere near the only cause. It's not. It's one of many, many contributors, each of them relatively modest, to ADHD in the population. When we probe these data and slice and dice the data, various stratifications, publication bias, the results are somewhat mixed. The parent and teacher results, you can see that the way we did the study in our a priori analyses, we saw reliable effects, but when we began to push the data around with publication bias and other things, some of these effects got weaker. However, the attention tests were an exception. Those effects are robust, and that's important to note. It seems clear when you look at all these papers that food sensitivities contribute to ADHD. Food dyes are part of the food total effect, probably not the only effect in the food, but it's an identifiable and preventable one. The policy implications then kind of allow you to see what you want to see to a certain extent in these data, I think. If your stance is to protect industry until a product is proven harmful, then you're stuck with the problem that most of the models do show some effect, and the attention tests are robust. If your stance is you want to protect children until a product is proven safe, you have to contend with the fact that but not every single model shows a non-zero effect. So, however, I would put us back into the idea of effect size rather than p-value here. One of the errors in the early view of this literature back in the 80s, this literature was dismissed because so many studies had p less than 0.05, not less than 0.05, but they were very underpowered. And when you pool them, you start to see that these effects are there. Because I'm raced and also ahead of schedule, I'm gonna just show you a couple of the things I alluded to, and then have a lot of time to back up and slow down for if I lost you from moving fast and having small text for these slides. So one thing I want to point out here, just going to show you. This is the data on, this says diet responsive, but it's supposed to say hyperactive ADHD kids. The fact is that a lot of the ones that selected for ADHD also selected for diet responsive, so those are confounded. And in this small literature, you can't isolate any one variable. You can't have only FDA-approved studies of only general population kids with attention tests. I mean, if you start to end up with such a few number of studies, it's hard to know. But just looking at the parents first, you can see that the effect size is identical for studies of general population and studies that were selected for either hyperactivity or diet responsivity. When you look at the high-quality studies, for parents, you see the same story. The effect's a little bit smaller, but it's not statistically different. For teachers, the effect looks a lot smaller, but it's not reliably different. For tests, the effect is reliable either way. We statistically tried to compare, you actually can compare the effect sizes here. Obviously, this number of studies here is very, very small, so that between group comparison is very low powered, but there's no evidence of statistical differences. You can see the heavily overlapping confidence intervals in these groups of studies that the effects are not obviously only restricted to ADHD or hyperactive kids. I think I'm gonna leave it there, even though I have more time, because I wanna have plenty of time for discussion.